Yes. Good morning, everyone. Thanks for giving me this opportunity. I'll be presenting a multicentric prospective study by Espinosa Bravo et al. From Val d'Hebron Hospital on safety of conservative surgery with accelerated partial breast re-irradiation for isolated ipsilateral breast cancer recurrences, regardless of the immunohistochemical subtype. So, as we know that breast cancer surgery followed by whole breast irradiation yields excellent in-breast control rates and is recognized as standard local treatment for properly selected early breast cancer patients. And the long-term follow-up suggests that there is a ipsilateral breast tumor recurrence rates of approximately 10% in these patients, for which mastectomy is the acknowledged treatment of choice. As it concerns over the cosmesis after the new lumpectomy and also concerns the complications related to the previous radiation toxicities. So that is why salvage mastectomy is the treatment of choice here. But when we see the results of salvage mastectomy, the chest wall failure rates are around 15%. The range is 3 to 32%. And also, if we try to conserve the breast. So the in-breast re-recurrence rates after repeat lumpectomy alone were also high, ranging from 19 to 50%. So definitely there was a need for additional modality here, for which whole breast irradiation will not be answered because of the excessive toxicities to the organs at risk like lung, heart, and subcutaneous skin tissue. So therefore, there is a potential to explore the option of accelerated partial breast re-irradiation in order to achieve the acceptable OAR doses. So what they did in 2014 to 2020 from 3 university hospitals in Barcelona, they have selected 35 patients and prospectively followed them after a new lumpectomy and accelerated partial breast re-irradiation was offered. So the patients were selected. The age was more than 50 years, more than 48 months from the local primary treatment. Tumor size less than 2 centimeters. It should be isolated IBTR, no nodes present, no multicentric or multifocal tumor in MRI, no major previous radiation-related toxicities should be there, and breast volume to excision ratio should be favorable for cosmesis. Endpoints were second IBTR rate, 5-year regional free survival, metastatic free survival, and overall survival. So what they saw that out of total 35 patients, the median age was 65 years. Median time to IBTR was 154 months. The most of the patients, 77% of the tumors showed invasive component, and 51% of them were moderately differentiated. Out of the locations, 48.6% had recurrence in the same quadrant, 45.7% had in the different quadrant. Majority of the patients had estrogen receptor positivity, 45% had progesterone receptor positive, and only 70% overexpressed HER2 positive. So according to the subtypes, 33% were luminal A, 40% were luminal B, and only 17% were HER2 positive tumors. So what they did after lumpectomy, they had offered APBI in 3 techniques. 67% were given IMRT, and 27% with 3D CRT, and 6% with intraoperative radiotherapy. All the patients who were ER positive were given adjuvant endocrine therapy, and all the patients who were TNBC and HER2 positive, they were offered chemotherapy, and targeted therapy was given to all the HER2 positive patients. So on the follow-up of median follow-up of 37 months, there were 4 relapses reported. Only one was second IBTR, which followed in situ IBTR, and rest of the 3 were metastatic. It was seen that both the metastatic progressions after the invasive IBTR were ERPR positive and HER2 negative. Looking at the oncological outcomes, second IBTR rate was 2.85%, 5-year regional free survival was 82.4%, metastasis free survival was 85%, and overall survival was 93.3%. Looking into the literature, there is no phase 3 trial till date regarding salvage mastectomy versus breast conservation therapy. Although the published previous literatures they have proved that second recurrence after salvage mastectomy is comparable to the results with the second breast conservation therapy. This is from the literature from Jack Castro Breast Cancer Working Group. This states that in 217 patients, when salvage mastectomy was compared with accelerated partial breast irradiation with interstitial brachytherapy, the second IBTR actuarial rate at 5 years was 5.6%. And also similar rates were seen, oncological outcomes were seen in this paper also. 5-year overall survival was 88.7%, and excellent cosmetic outcomes to 85% were seen. To our knowledge, this is the largest propensity score matched cohort analysis in this subject, which is from the Jack Castro group, where 1,327 patients were included. And after a median follow-up of around 75 months, it was seen that there was no difference in 5-year overall survival when salvage mastectomy was compared with second conservative treatment, 88 versus 87%, and no difference in cumulative incidence for third event were seen. And 5-year cumulative incidence of mastectomy was 3.1%. So far from these papers, we can see the oncological outcomes are almost comparable, but in the present paper, they have mentioned regardless of the immunohistochemical status, but the HER2 positive, which generally do worse, they are only 17%. So we cannot come to a conclusion from this paper regarding the prognosis from the immunohistochemical status. Now, regarding the toxicity from radiation, this is a paper by NRG, RTOG 1014, where 1-year toxicity was reported by after repeat breast preserving surgery along with 3D CRT accelerated partial breast irradiation, where it was seen that treatment-related skin fibrosis or breast pain adverse events were within the acceptable limits. So in terms of toxicity profile also, we can offer re-radiation, accelerated partial. So from this paper, we conclude that conservative treatment with BCS and APBRI for isolated breast tumor recurrences after BCS seems like a feasible technique as an alternative to mastectomy in selected cases. So there should be, to mandate this, the phase 3 trials should be conducted. So the choice remains between two salvage treatments should be totally on the basis of the tumor profile, the cosmesis, and the cutaneous and subcutaneous consequences of the first radiotherapy. Since the local rates from the previous discussion states they are similar, it seems like a feasible technique. And finally, the patient's choice matter. Thank you.